Okay. Welcome, everybody. Happy holidays. It's a happy holiday edition of Fireside Chats with our wonderful host, epidemiologist Glenn Grossman. I am our moderator, Rebecca Berman, and I'm thrilled to be here with you. Thank you to everybody who has sent in questions during the week. Glenn has been working very hard to incorporate all of your questions and his answers into his slides for tonight's presentation. And please, if you have questions that come up during tonight's discussion, please send them to me privately through the chat box at the bottom of your screen. Look up Rebecca Berman, and I will try my very best to weave your questions into our conversation. And if for some reason we can't get your questions answered during the conversation tonight, Glenn will absolutely work during the week to answer your questions and weave those answers into next week's conversation. So Glenn Grossman, as we know, is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology, forecasting, and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, Military Health Service, CDC, and other programs within the United States and abroad. We are very lucky to be with Glenn tonight to have all of the answers to so many of our questions tonight. And as always, all views expressed today are his own. So Glenn, where are we? What is happening around the country?
Thanks, Rebecca. That was great. So let's see, let me dive in. Let me open up my Zoom. All right, so actually here, there's a better way to present this. So we are actually looking a little bit better this week. I think part of it is an illusion. A large part of it is an illusion due to Christmas, that there were a lot less tests and things from Christmas. So you'll notice, for instance, here that the death rate appears to have dramatically dropped over the last few days. And that's only because there was just not a lot of reporting of the deaths. There was nothing to make the death rate drop. I wish there was something so dramatic to make it drop so quickly. But you'll notice that the hospitalizations haven't been going down. Rather, they've continued to climb. And so as a result, whenever we see anything going down, it's simply that there was less testing, there was less people reporting their the cases. Some of it is real. So for instance, when you look at the regions, so we've seen the Midwest have a pronounced decrease in cases over the last few weeks. And so I think that this is real, this is great. We also see over the last couple of weeks, a decrease in cases in the Northeast, the South. This is a little bit dramatic. So this, I think, again, is a reporting thing. And then in the West. So we are maybe just about starting to turn, but this was before Christmas results are really starting to be represented here. And so a lot of us are expecting, with all the massive traveling that occurred and whatnot through the Christmas holiday, that we're going to start to see it go up again a little bit. And I think New Year's will start to go up again a little bit. When we look at what this means for regional hospitalizations, so you'll notice that the Midwest has been going down. They're still very, very high, but they're definitely going in the right direction in terms of the number of hospitalizations. The South is continuing to climb. West is continuing to climb. Northeast looks like it could be continuing. I mean, this Christmas is still not incorporated here, but it might be leveling off, but it's probably going to continue a little bit. But that's what makes me think that that the cases are probably more just a data thing rather than a real effect. But we'll see as over the next few days, this coming week, as more data is reported, then we'll see. When you look at the death rate regionally, so some of this dramatic drop that we see is simply just because of the Christmas holiday and the weekend following that. We just haven't had a lot of people reporting, because you figure if people are working so hard, these healthcare providers in the hospitals are working so hard and dealing with people dying, they don't want to waste all their Christmas in just doing paperwork and submitting this stuff. So it's totally reasonable to say, have the weekend off and come back and enter the paperwork on Monday or Tuesday. So that's why these numbers drop down a lot during this time of year. We saw a very similar type of effect in Thanksgiving, where we had this dramatic drop, what seemed like a pretty dramatic drop, but then it just rose very quickly back to where it had been. And everyone's quite confident that that's what we're going to be seeing here. In terms of the reproductive value, so some of this is an artifact, just in terms of the reporting. So we don't know exactly how much of this is real. I do think that we are about to turn the bend on this. And so I am enthusiastic that I think when you look at, we'll get into the forecasts in a little while, but a lot of the major forecasts are assuming that we're going to reach the peak in around mid-January. So, and that'll be after Christmas and New Year's Eve are all incorporated into that. At that point, people are really going to hunker down for a while. They're probably going to be more willing to physically isolate for a while. And so I think that we'll hit the peak around middle of January or so, early to mid-January. And so the numbers are getting a little bit lower. So you can see in many states, they're below 1. And that's where we want to be, below 1. Ideally, we'd be far, far below 1, because when we're looking at the numbers here, you'll notice that the deaths, when they rise rapidly, but then when we decrease over time, they go down on a very, very slow slope. And so what we'd really want is for them to, unfortunately, if they rise rapidly, we'd want them to decrease rapidly too. And so in order for that to happen, the R value would have to be much, much lower. But right now it's below 1, so that's good. And you see in all the peaks that we've had, it's risen, and then it takes a much longer time to go down. And so I think that even though we'll reach the peak in January, middle of January, it's going to be months until we get it back down to 0. And we can talk about that in a bit. When we look at, so let's see. I can look at mobility. So here's mobility. Los Angeles was hit pretty hard. This is looking at cell phone data. It's a cool website. I think I've brought it up previously, but basically it's a really interesting way of seeing how mobile people are. How much are they moving around? And that's typically a good indicator of physical distancing and whether they're just being cognizant in general of not spreading the virus. And you'll notice that in Los Angeles County, which is being hit hard now, they dramatically reduced it back in March, April. It went up a little bit. It's still pretty high. It was reduced a tiny bit, but not where it should be. When you look at the United States as a whole, oops. So the United States as a whole here, where we dropped down in March, April, we started going back up with transit. You can see that it's still far below where it was. Rather, this is transit. Our driving went way up high, and then our driving now has come back down again for the country as a whole. We're still too high. Theoretically, we should be back down to where we were back in March and April for this to really be preventing spread. But you'll notice there were some dips. So a lot of this is due to variation weekly based on weekends and things going on. But it's still too high. But you'll notice at least we went down from where we were in the summer. All right, that's basically it. I'm not going to go into too much more detail today. The key takeaway is I think that we have seen some reduced deaths I don't think that it's, I think that this is more of an artifact of what we're seeing, but I think that some regions, for instance, the Midwest, really are doing a lot better than they were previously. The one other thing I'll show that I think reflects this well is the hospitalization data. So the best way to look at this is per million, so per uh, adjusted per the number of people that live there. And so you can really see which states are being hit the hardest now. And so you see that some states over here in the Northeast are being hit pretty hard. Delaware is at the highest that it's been. New Jersey is not as high as it was back in March, April, but it's still pretty bad. But you can see that the over the last couple of weeks, the slope has been going, not getting as fast as it was previously. So that's good. New York, it's still rising, but you can see Pennsylvania, it looks like it might have peaked a little bit. So you can see that some states are doing a lot better. Arizona is now going back up again. Nevada is going back up. California, which was doing bad, they've had some lockdowns, still hasn't reached its peak. But so you can see this is where we are. But the Midwest generally, which was doing so poorly, like North Dakota, you can see this is real. They really have reduced the number of hospitalizations. South Dakota as well has come back down. So the Midwest is legitimately doing a lot better. But this is all based on the R value, and the R value, which we'll get into a little bit later today, is based on the current level of physical distancing and mask wearing and all of these interventions that we do to prevent the spread. So if as soon as we take the masks off and take the and stop physical distancing and spend more time indoors with other people and go to bars and stuff, then the numbers are going to rise. All the numbers that we're seeing here in terms of the peaks are all based on the current physical distancing and mask wearing and everything that we have in place right now. All right, Rebecca, let's start with questions. We have some interesting ones tonight.
Thank you, Glenn. Thank you for all of your great maps and charts. Really, really helpful. So you showed us a bit about the peaks that you're predicting. When do you predict this will be all over? And can you talk a little bit more about the vaccines and vaccine hesitancy? Has that changed a little bit? How are people starting to feel about vaccines?
Yeah, so before that, let me jump back into the peak depth, what we're looking at, because I think this is somewhat interesting to spend a couple of minutes on. So I talked previously that you can see that the peaks, the previous peaks, we've had 3 surges so far. The first surge took around 4 weeks to get from virtually nothing to the peak, and then took approximately 11 weeks to get from the peak down to the lowest point that it was at. Then it took around 4 weeks to get up to the peak again, and also coincidentally around 11 weeks to get back down to around the lowest point. Now this point since then to go up to this last surge, it's been around 10 weeks so far, maybe nine or 10 weeks so far into it. Based on the projections that we're assuming it's probably going to be middle of January or so that this, until we reach the peak of daily deaths. We're looking at probably a total of 12 weeks up. And so, like I said, because you can see that the slope down takes a lot longer. So the number of people that die on the way down is actually far more than the number that die on the way up, because it's over such a short period of time. So the area under the curve of this long period on the way down, there's actually a lot more people that die. That's why I really wish we'd spent more time reducing the R value, reducing the spread by having some shutdowns. Even just a couple of weeks shutting down would dramatically reduce the slope and save many, many lives. But anyway, so the current projections are that around January 15th, potentially a little sooner, but give or take, is when we're going to see the peak daily deaths. If you take the slope line of where we were prior to Christmas, like at this slope, right at this period, and just project it for a few weeks out to that January 15th point, then I think we're going to peak at slightly over 3,000 deaths per day as a daily average over the past week. And so that looks like what, 3,000, 3,100, somewhere around that. But then after that, we're going to have a period where it's going down based on how long it's been taking for these other surges to go down. I'm expecting that the surge will largely drop down to around the levels that are still too high, but down to the lower levels that we've had back by April or so. But that by that time, once the vaccines have rolled out and a lot more people have been infected, then I think that when we were looking at May, June, we can really start, and particularly over the summer, July, August, the numbers are really going to get very low around the country. There'll still be some, lots of cases, but not nearly as much as we've had. I think the worst of it will be over by May, if not sooner, depending on how fast vaccines roll out. And by summer, this coming summer is going to be far, far different than the past summer was. It's going to be far less cases that we see, I think. All right, now you had a question about vaccines. Let me jump to that. All right, so first here, let me jump to vaccine hesitancy. All right, so this is a survey that I've been tracking. It's from the Morning Consult, and there's a lot of different ways of looking at vaccine hesitancy. This one asks, I know that we have a very polarized country right now, and it's interesting because when you look at a lot of different dimensions and demographics, there's not as much variation as there is based on this one characteristic of whether someone is Democrat, Independent, or Republican. And it's interesting. So Democrats are much more motivated to get vaccinated. So we're looking at above 60%. So we're looking at roughly 65% or so are willing to get vaccinated. Whereas Republicans and Independents, it's a little bit less than 50%. And so this is unfortunate. This is all based on messaging, unfortunately, and it's our government just failed here. It's kind of like smoking. Like the whole idea that smoking is bad for our health was a public health communication thing. Almost everyone in the United States realizes now that smoking is bad for our health, and even people who choose to smoke understand that smoking is bad for our health. But that was all a public health communication strategy that took decades to roll out. And the sooner we had done it and the more effective we had been earlier, the more lives could have been saved. With the vaccines, it's the same issue. This is not a subjective thing. This is really a science-based idea of whether people should get vaccinated. And it's really a lack of communication, effective communication for the public health reasoning and the science behind it that's really driving the differences, which is unfortunate.
Hey, have me unmute to ask my question.
Whoops, Rebecca, can you mute? When you look at the surveys of people who are currently interested in getting vaccinated, so let me just look at this one for a second. The average among all adults is slightly below, it's roughly 55% or so, it looks like is the green. When you look across states, you see that there's wide variation across states. This number is actually among this Facebook survey, there were a lot more people who expressed motivation to get vaccinated. And so the average from the Facebook survey was closer to 75%, 75% of people who across the country who are motivated to get vaccinated. But you see wide variation. Some states, it's under 70%, whereas some of the darker states, it's over between 80 and 84%. And it seems like there's a slight trend over the past few weeks for people to be slightly more motivated to get vaccinated. It's still just a very slight trend. But what I think what you'll notice back in March and April, there were a lot more people who were motivated to get vaccinated. And that's because of their fear and the stress that they had from the shutdowns and from the virus. But then it sort of eased over the summer and sort of hit this low around October. I think that as winter proceeds and the caseload increases, hospitalizations increase, and more people know people who had SARS-CoV-2 and perished from it, I think that vaccine motivation is going to go up again. And especially as more people see other people getting vaccinated, then they'll be more motivated to get vaccinated as well. The one other thing is in mandates. So because there are a lot of people who are not motivated to get vaccinated, that means then there might be a gap in terms of a lot of people in society that just aren't vaccinated. So for instance, some of these states you see, there might not be enough people vaccinated to get to herd immunity or really to be sufficient. So then the question becomes, do we think about mandates where the government forces people to get vaccinated? And so there have been some interesting surveys asking the question, should mandates be okay? And so, for instance, this one in particular was asking, should mandates be okay for children to be able to go to school, that they be vaccinated? We already do have mandatory vaccinations for children for other types of vaccines. So it makes sense that we would have one for SARS-CoV-2 if the clinical trials came through, demonstrated it was safe and effective, and that there was a reason to. Right now, I'm not convinced that there is a reason for a mandate in children, but the survey was interesting of whether people would believe it if the scientific community reached consensus that it was important, that they think that it would be acceptable for there to be a mandate. And it's interesting if you look at the variation. I'll try to make this as big as I can. If you look at the variation, overall, a slim majority believe, so roughly 50% believe that it should be acceptable to have mandates for children to get vaccinated for SARS-CoV-2. Under 40% say no. But it's interesting when you look at Republicans versus Democrats, this explains it almost better than anything else that I've been able to find. So when you look at Democrats, approximately 70% say that they're motivated that it's acceptable to have these mandates for children to get vaccinated, whereas it's almost the opposite. So only around 30%, 35% or maybe a little bit less, around 30% of Republicans say it's okay for children to have mandates to get vaccinated. So this is opposite, and it's very weird. When you look at things like race, there is some variation by race, with Asians sticking out, that Asians are far more willing to accept the science if it justified having a mandate for children based on just the idea of it being acceptable. When we look at some other things, so this is for children, when we look at some other populations, mandates for adults in general, you see that there is more acceptance. So over 60%, so maybe not quite as much. It's interesting. It looks like Democrats are more motivated to have their kids vaccinated for SARS-CoV-2 than themselves. And it's a little hard for me to interpret that. But it looks like for adults at large, there's slightly less motivation for mandates for adults. Democrats over 60%, Republicans under 30%, independents are much more hesitant to have vaccinations. And then when you look at it by race, there's a lot more variation. You see that Blacks, given their history of, there's been a large history of discrimination in medicine, they're very, very hesitant to get vaccinated. It's unfortunate because Blacks have been among the hardest hit from the COVID-19 epidemic. And so we really have to work on our cultural competency to increase motivation in that group to get vaccinated. But also Asians are less motivated as well, it looks like. But then finally, and this is one thing that's interesting, when you look at employees, so the federal government has given guidance that it is legal for employers to refuse for people to come back to work unless they get vaccinated. So it's the question is whether a company can force an employee to get vaccinated with a mandate. And so the question is, who supports this? And you'll see that there is a little bit more motivation generally relative to not, but it's still roughly 50% for in general across all populations. Democrats, again, are, between 65 and 70%. Republicans, a little bit more than 30% agree with it. The racial variation exists, but it's not huge. You can see the error bars are pretty big, but there is still some variation. This will be interesting to see how that plays out, because most people who are motivated to get vaccinated in the States will have had an opportunity by June or July to get the first vaccine. And so then at that point, we'll have a really good sense of what it's going to take to get the rest of the population vaccinated who are not motivated to get vaccinated. And so that means the May, June, July period is going to be a very interesting time to see who gets vaccinated and how the government approaches this with the new Biden administration. I think that with the vaccine hesitancy, like I said, when you compare it to sort of the anti-smoking campaigns that the CDC and public health organizations did, they were effective. We know what kind of communication works. So I think we can bring the population on this journey to understand, especially when so many millions of people have been vaccinated by that point, that we can get more people personally motivated to get vaccinated. So we might not need mandates, but it's going to hit around the May, June, July timeframe where we're really going to have to start looking at that, where there's, we'll see who hasn't gotten vaccinated and what can we do to stop any spread that's continuing. All right, Rebecca, I think that was it for vaccines.
Thank you, Glenn. Okay, so Dr. Chanowski, I'm sorry, I just fumbled your name. Excuse me for that. I'm going to ask you to unmute. Let's see.
You're not the first one to miss my
Sorry
name.
about that. So you have a great question about folks getting the vaccine, and I'll let you ask your terrific follow-up question about.
So now that people are starting to get vaccinated, my question is, are those people still able to transmit the virus?
That is a really good question that no one has an answer to. So there is still some likelihood that the virus can be transmitted. And the reason is that the vaccine is given intramuscularly. So it's given over here, enters the body, and basically the antibodies in the immune system responds in the bloodstream and systemically. The problem is that when people are first infected, it's mostly happening in cells in the nose and the lungs. And the worry is that the antibodies might be strongest and the immune response might be strongest in the bloodstream, and that the antibodies might not be able to get into the nose or the lungs as much. And so if there's not enough antibodies in the nose, then there is this possibility that there could be reproduction. So there could be infection and reproduction in the nose. It could reduce symptoms dramatically. That's why the vaccines are so great, because they virtually eliminate severe disease. There is still a little bit, but they get rid of the vast majority of it. And so huge decrease in hospitalizations and deaths. It's dramatic reduction there. But when you're talking about spread, then that's a different question. And so if someone gets infected in their nose and their lungs, they might not have severe symptoms, but they might have asymptomatic spread. And that's a worry, because this is a real big worry, because the whole idea of a herd immunity threshold requires people to have protective immunity. And if people don't have protective immunity, if they can still get infected and then infect other people, then the whole idea of herd immunity threshold goes out the door, because then someone could, even with the vaccine, who knows, maybe they'll let their guard down and not wear the masks after that, have less physical distancing, in which case there might actually be an increased likelihood that the virus spreads to people who are unvaccinated and that they get sick. So we don't know the answer to this question. Most scientists are believing right now that in order to have the symptoms get so low, the only way to drive the symptoms so low with the vaccine is if the infectivity rate is also very, very low. But it hasn't been studied. It was not one of the critical endpoints that was really carefully evaluated with the vaccines, with the Moderna and the Pfizer vaccines that have been released in those clinical trials, with the data that's been released so far. And so I'm certain it's being tracked right now, but it's still one of these open questions. And that's why I think even after people are vaccinated for the next few months, there's going to be a lot of people in the government saying everyone still needs to wear masks, even if they're vaccinated. There still has to be physical distancing, because we don't want to start a new surge simply because people who are vaccinated assume that they can't infect anyone else, and then they start spreading it everywhere.
Okay, thank you.
Sure. There's also, let me see if as a follow-up, if I have anything there. No, I can talk about this for a second. So then there's the question, well, how often do we need to get a follow-up? How often do we need to get revaccinated? And so the to get revaccinated, right now, the protocol is to get the first vaccine, and then typically within 20 to 30 days, you would get the second vaccine. It varies a little bit between Pfizer and Moderna. And then that gives you a real persistent effect for some period of time. We don't know how long that period of time is, but we expect that it's going to start going down. There have been a bunch of studies trying to look at what that window of time might be. Are we talking about many years? Are we talking about months? Right now, we don't know. It's almost certainly at least 6-month protection. But I mean, 6-month protection is not a lot, because if people get vaccinated now, and you're talking about having to get, and so you get your first shot now, second shot in January, and then we're talking about having to get revaccinated 6 months later. So you're talking about June, July, having to go through this whole thing again to get revaccinated. I don't think that's really appealing to anyone. And I think that would be really dramatic. I really don't think it's going to only last 6 months. I think that we're looking at a longer persistence, but we really don't know yet. The other question is in the strains. So we've heard about the United Kingdom strain that's coming out. Since then, there have been a couple of other strains. South Africa, looks like there might be some variants there that might increase spread, and some other places. And so the question of that's a slightly different question is, well, will we need to get revaccinated maybe annually like we do for the flu, because there's enough of this drift in the genes in the virus that we should then shift the vaccine a little bit so it's more so it's better tailored to the new genes and the variants that might be circulating. And that question is still unclear. What we've looked at in terms of some other coronaviruses is that within 8 to 17 years, but I mean 8 years as a max, a lot of the antibody titers are gone for some of these other coronaviruses. And so that means that this is not something like a measles vaccine where you get the vaccine once and and that's good for decades. Instead, we're probably going to have be revaccinated at some point. We just don't know what that point is yet. Luckily, the virus is not mutating very fast. And as we start vaccinating people around the globe, then as less people get infected, the number of mutations are going to dramatically drop. Because if you think of it this way, that the mutation rate is a rate. Basically, let's say it happens among 1 in 1,000 people who are infected, or 1 in 10,000 people who are infected. When you have tens of millions of people who are being infected like we have now, then even a small risk of mutation is very, very likely to happen because you're throwing the dice so many times. But as a lot of people start to get the vaccine, and if there's much, much less replication, then that means the mutation rate is going to dramatically drop. And so this is a sort of an important reason that we should vaccinate our population in the United States, but we really, really need to ensure that people around the world are vaccinated as well, because that not only helps them, but it also helps us in terms of preventing future mutations. And it means we won't have to be vaccinated as much in the future ourselves if everyone around the globe is vaccinated, so there's not as many mutations that arise. All right, Rebecca, back to you.
So we have another question from the audience. Rachel Scherzer, I'm going to ask you to unmute. There you are.
Hi, everyone. Happy holidays.
Happy holidays.
So I had some questions about the death rate and it being so high. I guess my question is it actually higher? Like what, based on the number of, like, is it actually higher than it was before? Or is it just that there's more testing, so there's a higher rates of infection and death? And like, I would have thought that with the increase in treatments and now, you know, with Regeneron and BAM being approved for emergency use, I'm surprised that there's such a high death rate still.
Yeah, so there's a couple questions. So there's a couple parts to that. All good points. So the first thing, are the death rates still higher? Are they being overcounted? So the short answer is yes, definitely. The death rate, whoops, not there. This is what I wanted. Charts. So the death rate is real. There are a lot, our hospitals are still overflowing. Forget about this. This is a data issue, as I mentioned. But the number of people dying is still huge. And we know because the number of people hospitalized is still huge. To your question about the monoclonal antibodies, the problem with the monoclonal and polyclonal antibodies is that hardly anyone knows about them. And it's so sad because I have mentioned previously, the drugs only work if you get them before you develop severe symptoms. And the problem is that most people who don't have severe symptoms don't think that they need to go to the hospital to get this drug. It's only when you start having severe breathing problems and you require oxygen and you go to the hospital that you first would think, oh, let me have a drug. But the second you have a severe symptom, the drug no longer works on you. It's too late, because then it's an immune system issue thing that's been activated at that point rather than a virus question. So really, these drugs need to be taken much more widely. So people who are aware of them still can get them typically. So you can still access them if you know to look. So everyone who's listening and who have friends who have people who are at high risk, we've talked about the risk factors before, please, please, please do whatever you can to get them the treatment ASAP before they develop severe symptoms. Because again, once they develop severe symptoms, they don't know. And so the problem is when you look at the hospitalization rate, the hospitalization rate is still going up, is still high. None of these people are eligible for the life-saving drug. It only works before you get into the hospital.
So then,
And so, yeah.
no,
please go ahead.
I was going to say, so as a follow-up, or in your view, why is there not like a wide communication or marketing effort to ensure that people are made aware of it? Obviously, it's an expensive treatment. Is it just about why wouldn't this be well known?
Yeah, so typically, I work in pharma, and typically there's massive marketing budgets that go into drugs and stuff. In this case, I would have expected a massive collaboration from the federal government, where the federal government sort of invested the money to tell people about this drug. And that campaign never happened. I haven't seen any television commercials. I haven't seen anything. And so no one is funding it. And it's a real shame. I would have expected for a public health issue like this should have come from the federal government, and it just didn't.
I will say in full disclosure, and I want to thank Glenn publicly for everybody, that without these calls, I would never have known about it. My parents did receive the treatment, and I'm convinced that it probably saved their lives because they definitely both were in, potentially high risk areas. So if not for these and Glenn's expertise in education, I'm telling you, I would never have known to ask. So thank you, obviously from the bottom of my heart, but everybody seriously ask for it if you know anybody that is sick and recently diagnosed. So my little public service and public thank you.
Thank you very much, Rachel. That's so great to hear. I'm glad your parents are doing well. Yeah, so yeah, I think the other issue, maybe one other reason that there hasn't been a lot of marketing and education about the availability of the monoclonal antibodies is because there still are not a lot. It's still somewhat scarce. And so you sort of have to balance, how well do you market it and make people aware of it with television ads, where then you'd have a huge rush of people going for it, but then there's not enough available, versus having it available, but then no one knows about it. Because then it's this really tricky thing. But yeah, they're making more though. So I think in the coming months, between the vaccines and the availability of this drug, I think we'll be much better off. The one other thing that's unique about this drug is that it's an infusion. And so an infusion, so that's an IV. And so you need to go somewhere that's a hospital or a clinic that can do IVs. So it's not just a regular doctor's office that you need to go to. So because it's a little tricky, and some people would maybe need to go to the hospital to get the treatment, most people would not think that they would need to go to the hospital without severe symptoms. And so it's this tricky barrier to care. All right, Rebecca, back to you.
Okay. Well, Rachel, thank you. Thank you for your great question, and thank you for sharing your experience. We wish your parents a continued speedy recovery. And Glenn, thank you for sharing your expertise. We're so glad that Glenn was able to be helpful in this instance and many, many others. And really, Glenn, we all cannot thank you enough for keeping us all safe and sound on this long, long journey. Thank you. So here we go, on to the next questions. So another great question has come in about, can we predict who will become a COVID long hauler And how will we know which types of folks will have long-term symptoms? Are there any ways to predict this?
That is a great question. All right. So we've talked about long haulers in the past. There's a few different names that are starting to be used to describe people with this experience. Long hauler was used at the beginning. Now in the literature, sometimes it's being called chronic COVID. And so approximately 10%, which is huge when you think of all the people who have had COVID-19. And again, the distinction between SARS-CoV-2, the virus, and COVID-19, the disease, is the COVID-19 are people who not only have the virus, but have the symptoms and have the experience of the symptoms. So apparently approximately 10% of people who have had COVID-19 are long haulers, have chronic COVID-19. That's a lot. When we're talking about millions of people who have been infected, and many of them have had COVID-19, this 10% is a very large number of people we're talking about. And so there's been a lot of research trying to identify who are these people, can we predict who they will be once they're infected. And we still don't know what is causing this long hauler syndrome. We don't know. There's a few ideas. One idea could be that there's sort of a chronic infection. And because there's a low grade chronic infection, that it just continues to produce a very, very small viral load that's undetectable, but that's still triggering the immune system. And that's why these symptoms persist. And that's one hypothesis. Another hypothesis is that in the process of developing an immune response early to the infection, it could trigger an autoimmune type of issue or some other type of issue where the virus is then cleared, but the symptoms persist because of variations in various immunoglobulins or other immunological components that are then sort of treating the body almost as if it's an autoimmune disease type of thing. A third type of question of hypothesis is maybe the virus might be integrated into human DNA. So we know that the SARS-CoV-2 virus is an RNA virus, and normally an RNA virus can't get into the nucleus of the cell, so it doesn't integrate into the human DNA. But there's this hypothesis now that's really curious that I'll spend a minute or two after this talking about, and it seems like there is a possibility that the RNA might be transcribed back into the DNA. And if that's the case, it's been shown as a proof of concept in petri dishes, but not in human bodies. So we haven't seen it actually demonstrated in people yet. So we don't know if it's the case. But if it is, that would be a third hypothesis, that maybe once the genes are incorporated back into DNA, and if that's the case, by the way, if it's this third hypothesis is true, it's probably not the case that it's the full virus that's brought in. So it's not something that can continue an infection. Instead, it might be just random clips of RNA that produce very small pieces of protein. And those random pieces of protein that are then brought into the DNA would then just continue being churned out and could be stimulating the immune system. So it could be this one of the reasons that we have this persistent immune response, even if there's no active viral replication going on, because the proteins from the virus that have been reintegrated are still being pursued. So that's something that's interesting. In this study, looking at trying to predict who will be a long hauler, there were some really interesting findings. So first, let me talk about the symptoms that are common in long haulers. All right, so here are the long hauler symptoms. The most common one is fatigue, so persistent fatigue. This is extremely common in autoimmune diseases, across almost every autoimmune disease. So myalgia, so the muscle pain, chills, brain fog is also extremely common. Arthralgia, burning sensations, temperature sensitivity, chest pain, tachycardia, the heartbeat, cough, shortness of breath, neuropathies, so the feeling of tingling in your fingers and other neurological components. Sometimes there's dermatological things going on, gastrointestinal, insomnia, and some people even have persistent loss of taste or smell. And so you can see that this affects so if we're talking about, again, long haulers representing maybe 10% of all people who have had COVID-19 have persistent symptoms, and that maybe a third of them are having continuing fatigue. That's a lot of people that we're talking about across the United States who have not recovered from this infection. And so this is another reason why people should avoid getting infected, because people think, oh, if you don't die, that you've cleared the virus and have completely recovered. And it's just not the case. We know that 10% have these long symptoms, and a lot of these symptoms are really, really interfere with daily life, with working and with doing the daily things that people need to do. When you look at the predictors now, so these are various components of the immune system. So the biggest one, the one that was most predictive of being a long hauler, was people who have high levels of interferon gamma. Interleukin 2, interleukin 6, interleukin 10, and interleukin 8 were also very likely to be predictive. And so luckily there are some drugs on the market for these, because having high interleukin 6, interleukin 10, all of these correspond to various disease states, typically autoimmune diseases. So it could be rheumatoid arthritis or dermatological issues such as atopic dermatitis or other things. And so as a result, there's a lot of drugs out there to treat this, but we also have pretty good tests to identify the different immune system components. And so that means that we can already, just based on this alone, probably have a pretty good idea based on the tests that have been conducted now, or the tests that are developed based on these characterizations, who is likely to become a long hauler. I don't know that how much of a difference it should make right now in terms of identifying people, because everyone should avoid the getting infected as much as they can. But among those who are, this could suggest possible treatments for the for long haulers, so that people who are suffering from all these symptoms that we just said, because there's some drugs that are out there, I'm confident that they're being investigated in clinical trials, and we should have hopefully some better treatments available to help these many people now going forward. All right, Rebecca, back to you.
Interesting. Okay, Glenn, we will definitely keep our eyes on that one. Sounds like more to come. Okay, so let's shift gears a little bit here. We are about midway through the school year, so to speak, in some cases. And what do we know? What can you tell us about schools, different age groups? What are the different factors? What have we been seeing, and where have we been? Where are we going?
All right, so we know a lot more now than we did back in March or April. And so the evidence is very compelling. So I'll walk you through. This might be surprising to people. So basically, in the United States and in numerous countries now where it's been investigated, I'll share a couple in the US and abroad to look at. We see that children who test positive for SARS-CoV-2 are more likely to have attended weddings, parties, play dates, funerals, or other things, but are much less likely to have attended school in person. So this is counterintuitive. Let me say this more transparently. Kids who study from home and are remote are more likely to get SARS-CoV-2 than people who go to in-class learning. And this is a very surprising finding. So I'll go into this a little bit more, but it seems pretty consistent from a bunch of different data sources at this point. So here's one study that we're looking at. This was Mississippi, September through November. They were looking at, let me see if I can make this a bit bigger. So here they were looking at kids under the age of 18, what was predictive. So these kids who were in close contact with a COVID-19 case, they were much more likely to be to get infected. And so what might cause them to have to have close contact? Well, if they're spending their time at home because they're having all the Zoom classes, then they're probably spending more time with the parents, And if the parents are going out, they figure, oh, the kids are probably safer because they're not going to school. And so there might be more opportunities for the kid to get sick. They might be going to the store with the parents. They might be going food shopping with the parents. And they might be doing things that might be putting them at slightly more risk. When you look at in-person school or childcare, it's not dramatic. It still crosses the 1.0, which means that it's not statistically significant. What is that people who attend school aged greater than 2 years and staff members were statistically significantly less likely to get SARS-CoV-2. Household members who work outside of the home were not meaningfully more likely to get to have those kids get SARS-CoV-2. Household members who work in healthcare were not much more likely. The kids who attended social gatherings. I think that one thing that we found is that if parents are keeping their kids home and are having their kids do remote school, then they think that their kids' risk is lower generally. And so because of that, some parents might be letting their guard down and say, well, they're not going to school, so maybe they can go to this one wedding, or maybe they can go to this one party or funeral. It's a family member, they can go to the funeral because they've been home all semester without, how could they possibly have gotten infected? And so the reality is that this is statistically significant, that this is really what's driving the infection in kids. People who are going to school are not getting it. It's the kids that are staying home, and more particularly the ones as a result that are having smaller numbers, so infrequent, but more high risk activities like the weddings, parties, that kind of stuff. Child gatherings, including birthday parties, play dates, that kind of stuff. Some parents might think, well, the kids have been out of school, what's the risk? They've been doing Zoom. Well, it's okay if we have some play dates or something. Well, guess what? This is dramatically increased risk of having the kids get infected with SARS-CoV-2. Travel actually, interestingly, has not been, there's a very wide error bar though, so it's a little hard to interpret. Visitors in the home, again, statistically significant. The parents believe, oh, the kids are home, they're safe. But even having a package delivered, someone could come to the door, deliver the package, you answer the door, oh, thank you for the package, and guess what? Now you've just been exposed. That's why it's better when packages are delivered, have them drop the package at your front door, walk away, and then after they leave, then you open the door and get the package. But this is actually the visitors in the home is a source of spread for kids. Restaurants does not seem to be a big issue, but again, the error bars are small. It's a really interesting finding. And so when you look at this is one from Italy. This has been replicated all over the world, though, at this point. A lot of studies have demonstrated this at this point. And so Italy, the key conclusion here, our prospective analysis does not support a role for school reopening as a driver of the second wave of SARS-CoV-2 epidemics in Italy. In particular, here's a couple great graphics that I saw. All right, so these are in school, kids who went to school in person. All right, so these are kids aged 6 to 13. On the left axis, you can see newly reported cases per 10,000 students. So this is how many students get it per capita, roughly per 10,000. And over here is the population in which they live. If it's green, the closer down it is towards this axis, the better it is to be in school. And the further red it is, the worse it is for this activity. So you can see, and the black line is the break-even point. So you can see that among kids, and these are all different areas in Italy, among kids aged 6 to 13 who went to school in person, they were far, far less likely to get infected than the average would have predicted based on the amount of infection going on in their communities. It changes a little bit for people as they get older. So I've talked before about puberty being this really critical change point. And so kids who are between the age of 14 to 18, then you can see that the numbers change a little bit. It shifts up to the middle. So the risk is mostly for those kids. So again, the age is 14 to 18. The risk then is basically similar to what the population risk is, because anything on the black line means that the risk is roughly the same as the population. If the students are roughly the same risk as the population spread. Interestingly, is this question. And so this is an interesting finding here. So now when you look at faculty and staff at those schools, because this is an ongoing question, you see that faculty and staff do have increased risk. So this is a concern for opening schools. The kids have dramatically reduced risk by in-person classes, which is astonishing for a lot of people to think about, but the teachers have dramatically increased risk. So what this means is if we can find ways to have the teachers work more remote, but have the kids go to school, then that would be the ideal situation. So maybe you have a school aide, a teacher's aide, who is younger, who is at low risk, maybe in their 20s, early 30s, with no other comorbidities, and they could be in person, but then the teachers have a remote Zoom into the classroom. That seems like this would be ideal for a lot of the classrooms going into the next semester. So as we approach the spring semester, because the teachers and the staff are at increased risk. But the kids, like I said, especially for elementary school, this finding has been replicated around the world now, and I think is a real thing. And so this is something that we really need to consider strongly. Sending kids to school probably protects them more than keeping them home and having them do the remote learning. And that's not even taking into account the people who don't have access to internet and who need the in-person learning because of underprivilege and that kind of issue. That's a totally different issue. This is just in terms of the infection of SARS-CoV-2. So this is really interesting food for thought. Again, it's been replicated all over at this point, so I'm very confident in the findings. One other thing that's really interesting, when you look at this, so this is the same study from Italy. I like the way that they had presented this. When you look at the age range by specific ages, you can see that the people who are at lowest risk are the 0 to 4-year-olds. This is for in school, people who are going to the pre-K and the kindergarten and the elementary school in person. The ones who are at the least risk of getting SARS-CoV-2 getting a positive test, 0 to 4 is the very least, then 5 to 9 is the least, then comes blue, 10 to 14. After that, when they hit puberty, then you see that it starts to go up again, 15 to 19, then it starts to dramatically rise. And in particular, and this doesn't apply to college age students, that's a total different ballgame. They are young adults, they're at least as infectious as any other adult out there, but the difference is that they have a very high risk tolerance and they're going out and they're partying and they're spreading it like crazy. So you get the purple, which is the 20 to 24-year-olds, they're spreading it a lot. The 25 to 29-year-olds also spreading it a lot. Interestingly, orange, this is not typical of what we're finding in a lot of other places. Orange here, the 45 to 49-year-olds are in this study, we're getting it quite a lot. And so that's interesting. But the key takeaway here is these elementary school kids are unique, and we should probably for the spring semester be thinking more about in-person classes. We're gonna have to figure out ways of protecting the faculty and staff at the schools, but the kids seem like they'll be doing better actually in class, in person. Don't blame it on me, any kids who might be watching this or parents who communicate this to their kids. But yeah.
It's all Uncle Glenn's fault. It's all your fault. All right, so we're about at our time together. Glenn, what a year. What a year it has been. And as we've always have said to everyone in our audience, both live and those watching later on YouTube and otherwise, if you or someone in your family or your friends has been impacted by this dreaded disease, we are thinking of you and you're very much in our thoughts and prayers. And Glenn, we can't thank you enough for sharing this, your wisdom. You're well over 1,000 slides you've been so generous in sharing your limited free time with us. And if you could actually bring up that last slide with all of those little dots, because to me, what I think of when I look at that last slide, it actually makes me think of the fact that this week, at the end of this week, we are closing out 2020. And I'd like to wish everybody a very happy new year. And I'm going to look at that slide and I'm going to think of the confetti that's going to be falling all around the world And I want to wish everybody on behalf of Glenn, I'm sorry I'm co-opting your show here,
Oh, thank you.
very happy and healthy and an extra dose of healthy new year as we ring in 2021 together. Thanks again, Glenn.
Thank you, Rebecca, very much. And it's been a great year in terms of, I'm glad that you and I have been able to help all of these people who have had questions where we could dig a little bit deeper and help them to understand what's going on, maybe alleviate fear and stress a little bit, and also make people aware of the vaccines and the treatments, and really help people optimize our journey through this terrible epidemic. But thank you, everyone, for joining us. And in particular, thank you, Rebecca. See you next year. All right, bye-bye.